Hi all, welcome back to class. This week we're going to talk about opiates and opioids. This will be the last topic that we're going to cover before midterm 2. Remember that midterm 2 is not cumulative, so it will only cover the material since the last midterm. So that would be our amino acid neurotransmitters, our neuropeptides, and then opiates and opioids. So let's get into it. So first, what is the difference between an opiate and an opioid? It's pretty simple. Pretty much if a narcotic substance, something that comes from the opium plant, the opium poppy, then it's an opiate. Okay, so these are natural narcotic opioid alkaloids. Again, if it comes from the opium plant, it's an opiate. If it acts on the opioid receptor but does not come from the opium plant, then we call that an opioid. So an opioid can be either natural or synthetic compound, and it can also be an endogenous peptide, but all of these compounds will exert an effect on the opioid receptor. So let's start with opiates. They're a little more fun for those of you that are taking this class because you want to know about like the effects of street drugs and stuff. That's what we're going to really get into now, so this can be pretty fun. So first, we've got opium. Opium, I gave you the scientific name, Papaver somniferum. It's Latin for sleep bringing, and that really makes sense because opium and its derived substances are used for pain medication and to help relax. A lot of time they are in fact depressants. The majority act as depressants. Now, the cultivation and use of opium actually predates recorded history, so it's one of the oldest used drugs. We saw some descriptions of opium use in ancient Egyptian texts, how they used opium for medical practices. We found some ceramic opium pipes in Cyprus that dated to over 1,000 years BCE. We see it in Europe during the Crusades. Of course, we see a lot of it in Eastern Asia as well. There's evidence of opium use for thousands of years. Now, opium has also been kind of used not just as medicine, but also for recreational use. So in Victorian England, then there's actually this trend where they would actually dissolve opium in alcohol, and it was considered much more proper for a Victorian woman to drink this opium-laced alcohol than just common alcohol, because common alcohol was for the men. So women drank this opium alcohol. Ooh. It was also used, this laudanum, or this combination of opium dissolved in alcohol to be used as a cough suppressant or pain reliever for medical uses, but also, a fancy lady needs her drink. So that's just some history on opium. Now, what are some natural opiates? So remember, opiates are derived from the opium plant. So we've got a picture of the opium plant here. And obviously, a natural opiate would be opium. But then we've got some other major psychoactive opiates, such as morphine, codeine, and theanine. So morphine and codeine, you guys may be familiar with. Those are great pain relievers. Theanine, then we'll talk about a bit and how it's a unique opiate. And then we've got some other major opiates as well that you don't need to know, but I put their effects here. And then we've got some minor opiates. And so these minor opiates are things that, again, you'll probably recognize, like hydrocodone, which is the common name for Vicodin. We've also got oxycodone, so Oxycontin or Percocets. Those are minor opiates. So they are derived from the opium plant, though in the case of Vicodin and Percocet, then they are also mixed with some other compounds. So they're not pure opiates, but in general, just a hydrocodone or oxycodone would be a opiate. Now, what do these opiates look like? What is the chemical structure? Well, first, you should know that the first opiate to be isolated from opium was morphine, and it was first isolated in 1804, so it was in use since then. But we didn't actually know the structure of morphine until the 1920s. So we've got some natural opiates over here on the left side. We've got morphine and codeine. These are two natural opiates that are both analgesic, which means they have that psychoactive effect. They're depressants. They are used for pain management. But then we've got our third natural opiate, theanine. Now, theanine is very interesting because where morphine and codeine are depressants, theanine is a stimulant. So it is very unique, and it's thought that it's these bonds here that are making it so unique. And if you take too much of theanine, then it can actually act as a convulsant. So that's pretty exciting, and obviously theanine then is not going to be used clinically like morphine and codeine is, but it does provide a chemical feedstock for the synthesis of numerous other semi-synthetic opioids. So we're going to come back to theanine when we talk about opioids. Now, there are synthetic opiates. So the most famous synthetic opiate would be heroin. And you can see how it looks very similar to codeine and morphine and theanine. So it looks very simple. And this is due to those natural opiates having that have greatly varied effects due to a number of relatively minor alterations in the chemical structure, and this leads the pharmaceutical development of numerous semi-synthetic and synthetic opioids, like our heroin here. Now, what are some pharmacological uses of our natural opiates? So the first one, the one that comes to mind first, would probably be an analgesic. In other words, a pain reliever. So opiates are still the most potent and effective pain relievers known. They're very widely used. So this is both morphine as well as its derivatives. They are used in hospitals a lot. You know, when you're in the hospital, you have morphine, but when you're discharged, then you might get a prescription for codeine, that kind of thing. So it's still the most potent, most effective, most widely used pain reliever on the market. They can also be used as antitussive, or in other words, as cough suppressants. So codeine has decreased analgesic effects, but retains its antitussive effects. In other words, codeine isn't as good as morphine for to relieve pain, but it is just as good at being a cough suppressant. Okay. We also see decreased gastric motility. So our natural opiates can be used to treat diarrhea and other pathogenic gastric motility issues. So specifically, we've got loperamide is an opioid derivative that does not penetrate the blood-brain barrier and is used to treat diarrhea. So whereas morphine and codeine can or does cross the blood-brain barrier, this antidiuretic, loperamide, is an opioid that's derived from the opium plant and is used to treat diarrhea and is a good option because it can't cause behavioral effects because it can't cross that blood-brain barrier. Now, how do we administer our opiates? So natural opiates can be administered by a number of routes. So we've got oral administration, and this is great because morphine specifically is very easily absorbed through the GI, but there is high variability to it. So you could give like 3 people the same amount of morphine and they'll each absorb a different amount. So codeine is actually more consistent if you're going to give it through oral administration. And that's why you don't really see doctors prescribing morphine pills, but they'll prescribe codeine pills. And that's just because codeine is very consistent in its oral absorption. So with morphine, then you're more likely to see administration intravenously, intramuscularly, things like that. Also, subcutaneous is another option, but intramuscular and intravenous are the most common routes that you'll see for morphine administration. Specifically, intramuscular is the preferred morphine route in a clinical setting. So if you are in a hospital or something, they will give it to you intramuscularly. But codeine, opium, morphine, if they're taken in a recreational setting, then it's more likely to be taken intravenously. And that's because you're taking it to get the high feeling. And we know that intravenous is obviously the quickest route. So if you want to get high, that's going to be the quickest route. Again, I'm not telling you to do drugs, but I'm just laying the facts. You can take opiates via inhalation. So there is this is a historical recreational route for administration of raw opium. So if you're going to inhale it, a lot of people, if they are experimenting with opium, a common way is to smoke it. So like back in history when there were opium dens, things like that, then the route of administration was inhalation. They would smoke opium. There's a whole history that I would love to get into, but we don't have time on, about the whole like legalization and illegalization of opium and how it's all racist and everything. So if you want to know more about that, there's some really great stuff to talk about the history of why opium was turned illegal and how it's racist in the way that they did it. So if you'd like to look into that, it's very interesting. But now let's move on to things that you guys probably care a little bit more about because you're actually going to be tested on. So we've got our semi-synthetic opioids now. So we are no longer talking about our opiates. We are now talking about opioids. So the first semi-synthetic opioid that we'll talk about is diacetylmorphine, which was first synthesized in 1974 by this old white dude, C.R. Alder Wright. And he was looking for morphine analogs that were less addictive than morphine. Now, this drug went on to be marketed by Bayer Pharmaceuticals under the name heroin. Yeah, so old white dude made heroin so that there'd be something less addictive than morphine. Didn't turn out great. But heroin was originally marketed as a cough suppressant, as an analgesic, and a cure for morphine addiction. That's right, if you're addicted to morphine, you can cure that by getting addicted to heroin instead. And you can see how there's many issues with this. So there was a development of numerous semi-synthetic opioids that followed the synthesis of heroin, where they followed the isolation of morphine and codeine, and subsequent discoveries of the structures. So other companies were able to alter the structures of our opiates to create more semi-synthetic and fully synthetic opioids. So some of these semi-synthetic opioids are found naturally, but generally they are synthesized from morphine or theanine for pharmaceutical use. So the examples here would be that hydrocodone, hydromorphine, and oxycodone, which again they can be found naturally, but when we're using them pharmaceutically, then we actually are synthesizing them. Now, how do we administer our opioids? It's very similar to the administration of our opiates. So we've got our oral administration. Heroin by oral route does produce the same potency and efficacy of morphine. So it has a first pass metabolism of heroin, yields morphine as the major metabolite. So if you were to ingest or eat heroin, the first pass through your stomach and liver, then what's going to happen is heroin's going to be metabolized into morphine, and then the morphine will go into your system. Intravenous IV of heroin is much more popular in a recreational setting. It's dramatically more potent. It's much more rapid because it does have this increased lipophilic structure. So it crosses the blood-brain barrier much better than just plain morphine does. So we get that rapid uptake into the brain where it will then be metabolized into morphine. And so it's going to exert its psychoactive effect. So heroin's still going to be metabolized into morphine, but by crossing the blood-brain barrier as heroin, then more of the heroin's going to be able to cross quicker than if it was pre-metabolized as morphine. Now you can also take our semi-synthetics as inhalation, so smoking or intranasal. These are occasional routes for recreation, but it's not as common. So there is this thing called freebase heroin, which is like a powdered heroin that you can smoke or you can grind it pretty finely and snort it. So that's where we're going to end it for this video. And in the next video, we're going to start talking about some of the therapeutic effects of opioids and how all of our opioids and opiates